Somik, thanks for those kind words. I will not talk anything further other than actually go into the debate. You know, you feel so happy when you sort of smell success, Somik, to be very honest. And I think this premixed insulin, you know, when you said triumph, I heard trumps. So what I heard was premixed insulin trumps over basal bolus insulin. So you as a chairperson are already for the motion. Having said that, the bottom line remains that 75% of Indian population at this point of time uses premixed insulin. I think that is the writing up there on the wall, very, very evident that that is what we use and that is what we do. I have not put up this slide, mind you, to tell you where we stand as far as these numbers are concerned. I have put up this slide to tell you that we need to treat 77 million people, mind you, with diabetes in our country. And when I'm talking about 77 million people who have to be treated with diabetes in our country, we know that diabetes is a progressive disorder and a huge number of these patients are finally going to be on insulin. If you look at the ratio of doctors to patients in this country at this point of time, it is 1 in 1,500. You are talking about an overburdened, an overstressed physician out there trying to look after these patients with a complex regimen. It's a big no-no. Add to that the big screwing of as far as the division between the rural and the urban population is concerned, as far as the healthcare provider is concerned. Again, you have a situation, a potential situation where you cannot afford to make healthcare more complex and more complicated. To add to this, we know we are a high carb consumption population. Whether you look at the START study, you look at the PURE study, across the board, you know that we love our carbs. 61 to 70% of our energy is from carbs. And what does that mean for you and me? What this means for you and me is that we have a significant contribution of the post-panel glucose to our A1C across the board, be it an HbA1c from 7 to be it an HbA1c of 12 plus. This was not what we were conventionally taught. This does not what we learned from the Monnier et al. Slide, but this is what our reality is. And this translates into 22% of people with diabetes having mind you, an HbA1c of less than 7%. And why is this? We're just talking about insulin, 100 years of insulin. We are talking about all the different kind of insulins available, but the bottom line remains that we do not initiate insulin. The DiabCare study over there showed that the mean HbA1c was 8.9%. Insulin therapy not initiated, no dose optimization, no intensification. So we do have a big problem as far as the Indian data is concerned. Again, over here, you would realize that the mean HbA1c in the cross-section registry-based retrospective study, again, 748 diabetic outpatients showed that the mean insulin dose per kg body weight and the total daily dose of insulin was low. So we are just not starting insulin to begin with. Now to that, if you add a complex regimen, 40% of the physician colleagues are saying that 10 to 25% of patients do not agree to start insulin. So we have these challenges. We have this challenge of a high carb diet. We have this challenge of high PPG. We have challenges of patients being on multiple OADs. At this point of time, our patients are not on those 3 conventional OADs that we used to talk about. Our patients at this point of time on 5 OADs before they even think about insulin. But when you want to make this switch, we know it is difficult. We need it to be simple. We need it to be convenient. So do we really have a solution? Or is it that we just simply don't have a solution? We are talking about patient-centric care, but do we really take patient challenges in mind? Do we take into fact that the patient is worried about injections? Do we take into account that insulin would not maybe available in a rural setup at all? Do we take into account that it is difficult for a patient to handle so many injections? The social stigma of having to inject before every meal, that is a lot of social stress to the patient. And at the end of the day, if the patient does not have insulin, simply insulin, the so-called complex, the so-called insulins available to them, you potentially have an absolutely lose-lose situation. To add to this, you have physicians who are overstressed, who are overburdened. And we know when I talk about insulin, I know Beatrice is going to say, oh my God, in your conventional insulin is going to have the issue of weight gain, they're going to have the issue of hypoglycemia. But we all know that if you start insulin slowly, if you start it intelligently, and in our patients, most of our patients have very, very significantly repetitive lifestyles, in the sense that they have an absolutely fixed life pattern. They have meals on times, most of them. Very few of our patients really have very erratic lifestyles. Very few of our patients would not be able to adhere to the dietary advice which we give them as to having small frequent meals. So though we do know that there could potentially be an issue of hypoglycemia, we also know that real world evidence, where they look at the A1 Achieve study, look at so much of the real world evidence in Southeast Asia, you would realize that no, that is not actually true in practice. But even in spite of that, the Dawn survey shows that yes, we do not initiate insulin because we are scared. We are worried. Oh my God, how am I going to manage? Is this regimen going to be too complex? Do I have to monitor too much? Is it going to involve too many injections? But the meta-analysis of Gugliano et al., I've just put in 2 slides about analysis because otherwise I could just hijack this entire symposium, which shows that when you compare basal bolus with premixed insulins, no difference with regard to changes in A1C, hypo, weight change, daily insulin requirement. But where is the difference? Number of injections, fewer friends with premix. SMDG, less frequent. Patient's ability to injection, much more convenient. And when it is convenient, it is going to be doable. We are now also moving to an era of co-formulations. IDEC asks, is it going to write a new script for the subcontinent? Because we know that, yes, you have better fasting control, you have better PP control, not only when you compare it with your basal glargine U100, but also when you compare it with your glargine U300. So across the board, we have better control. And that is the reason our guidelines say, yes, our guidelines, the IDF guidelines very, very clearly say you can initiate with once daily premixed or co-formulations, or mind you, twice daily premixed insulins, either alone or in combination with or other OADs, depending upon patient's age, clinical features, glucose profile, risk of hypoglycemia, and patient preference. So this means this is patient-centric care. This means that, yes, you are keeping the patient at the center of your decision and then making a decision as to what is best suited for your patient, keeping in mind that the caretaker, your physician colleagues who are looking after your patients, are able to manage their patients without having any additional issues arising. When we talk about initiation, it always comes to what about intensification? How do we go about intensification? Always the dilemma is that when we intensify, are we going to be able to achieve the same good? Yes, mind you, patients, even patients, for example, on basal insulin, finally are going to be switched to premixed insulin twice daily or premixed analogs twice or thrice daily. Again, a huge amount of data out there which shows that you can use your premixed insulins twice daily, you can use them thrice daily, and be able to safely reach target, be able to definitely reach an HbA1c of less than 7%. With there may be some situations of a mild increase in hypoglycemia, but this increase can be taken care of. You can switch to insulin co-formulations, which we all know have a much, much, much lower incidence of hypoglycemia or weight gain. Again, as I said, we need to change our thought processes and we need to keep in mind what is convenient, what is simple, what is doable, what is going to actually help our country from becoming diabetes capital to the diabetes care capital of the world. And both premixed insulins and co-formulations are acceptable methods of intensification. Co-formulations, as I've already said, gives you the advantage of a low risk of hypoglycemia and nocturnal hypoglycemia. So I think it is very, very clear over there that if you look at the total spectrum of care in our country, whether you look at the level of the patient, whether you look at the level of the physician, whether you look at from the angle of monitoring, which we again know has a certain cost involved, and whether you look at it from the term of long-term complications, which is the very aim of therapy. Your aim of therapy is that you want to prevent long-term complications in your patients. Across the board, you are going to have a situation where you could attain what you want to attain easily, simply, without creating any additional stress for your patient or for your physician friends. So we all know, friends, there's a lot of resistance to initiation and intensification of insulin. But if you make this simple, it's yes, so much. Last slide. It is definitely doable. Premixed insulin score over complex basal bolus regimens. And of course, simplicity with efficacy is the best way forward.
Thank you, Dr. Shehla. That was a strong defense of premixed insulin regime. Now we'll hear the other side of the story. Let's see how Dr. Beatrice Annie faces this strong defense by Dr. Shehla. So over to Dr. Beatrice, and exactly you will be cut short after the next 12 minutes. You have 12 minutes to prove your point.
Thank you, sir. A very good evening to all. I'm going to be talking against the motion, of course. And I thank Shehla ma'am for taking care of the statistics for me. Of course, we have 77 million people to treat with diabetes in India. And more than 75% of those patients who are on insulin or on premixed, yes, accepted. And unfortunately, less than 50% of our patients have reached HbA1c targets. So please connect the dots yourself. And when we talk about two regimens, we are going to talk about them in terms of certain parameters like the efficacy, the safety, the cost, the acceptability. So let's first look at the efficacy part. So there are many studies out there, but I just picked up a few to look at the efficacy as such between premixed versus the basal bolus insulin regimen in type 2 diabetes. In fact, this is a meta-analysis which has looked at the changes or the mean change in the HbA1c between the basal bolus versus the premixed regimens. And we know that in the RCT, of course, you have significant difference in the HbA1c or the mean change in HbA1c, which favors the basal bolus regimen and which is reflected even in the real world where we have HbA1c change, which favors the basal bolus regimen. And the Ginger study, which again looked at the basal bolus versus the premixed regimen, it showed that the HbA1c or it provided superior glycemic control versus intensified premixed insulin therapy. And let's have a look at this graph where the basal HbA1c was around 8.6, baseline HbA1c was around 8.6, which came down to 7.3% over 52 weeks in patients who were on the basal bolus regimen as compared to those who were on the premixed insulin, 8.5% to 7.7%. And most important is this. Let's have a look at the SMBG profile of these patients. You see this is the baseline here. And at the end of 52 weeks, we see here the smoother curve with the basal bolus as compared to the peaks and troughs, which are seen in the patients on the premixed insulin. And this is the LACE study, which again showed similar superior glycemic control with patients who were on the basal bolus regimen as compared to those who were on the premixed regimen. So this brings us to the most important question. So premixed versus basal bolus, which is more physiological? So let's have a look at the normal glycemic excursions here. So post-lunch, post-breakfast, post-dinner, we do have glycemic excursions. And we'll just draw this graph. This is something which is very common. So let's have a look at this. So this is the premixed insulin. So it is definitely going to take care of the post-breakfast, but it sort of plateaus down at the time of lunch. So the lunch, the glycemic excursion post-lunch is not taken care of. Whereas the basal bolus, where we take care of every post-meal glycemic excursion, where we have a smoother control of the glycemic excursions and we have a basal insulin to take care of the basal needs of the patient as well. This is important because it's just not about the fasting or the HbA1c, which we need to be really bothered about. But the postprandial blood glucose is something more important, I would say, in determining the complications in patients with type 2 diabetes. And this is more important in Indians because let's have a look at this study, which looked at normal Indians and normal Caucasians. And this is after a standard glucose load, and see the glycemic excursion in a normal Indian. So you can imagine for a patient with type 2 diabetes. So this is important because we need to control this postprandial hyperglycemia because it's going to lead to a whole gamut of complications like coronary artery disease, you have a diabetic retinopathy, nephropathy, neuropathy, stroke, name them, and you're going to be having them. So, and this sort of a subtle difference in glycemic control has been documented in almost all the studies which have looked at basal bolus versus premixed insulin formation. What I'm talking about is the glycemic variability here, which again, this is a study which looked at hospitalized patients who were on basal bolus and the premixed. And we see the smoother curve here of the basal bolus and compare it to the peaks and troughs, especially post-lunch, post-breakfast here with the premixed insulin group. So again, this is another Japanese study which looked at the glycemic variability between basal bolus and premixed insulin. And look at this smoother curve here with the basal bolus as compared to the peaks and troughs here of the premixed insulin. And the time out of range, that is a post-lunch especially, the time out of range more than 180 milligram per deciliter was significantly higher in the premixed therapy group than in the basal bolus therapy group. And this is a beautiful study from JCM, which looked at both type 1 and type 2 diabetes patients. And they were their own control. So 12 weeks, a patient was on premixed and another 12 weeks on basal bolus. And we see here the CGM data. So the daily mean blood glucose, the daily standard deviation is much lesser in the basal bolus group as compared to the premixed group. And the time out of range again was much lesser in the basal bolus group as compared to the premixed. So this brings about a very important question, that is the flexibility of the injections. Because the patients are going to be on premix, and there's going to be a set or 30% of the short acting and 70% of the long acting, there will not be much flexibility in adjusting the individual components of the premixed insulin. And at equivalent HbA1c levels, the risk for diabetes complications may be higher in patients with premixed therapy than the basal bolus therapy. And this is because the premixed therapy will not sufficiently suppress the fluctuations in the blood glucose or the glycemic variability, even at lower HbA1c levels. Next, we'll go on to the safety. And the most important safety signal that we have in any sort of insulin regimen is going to be the hypoglycemia risk, which again has shown to be lesser in patients who were on basal bolus regimen as compared to patients who were on the premixed analog group. And this is again in hospitalized patients. This was a comparison of basal bolus and premixed insulin. And in fact, this study had to be stopped early because the frequency of hypoglycemia was more than 50% in patients who were treated on the premixed human insulin. And this results of the Ginger study again showed that the total number of hypoglycemic events was numerically greater in the premixed group than the basal bolus. And this is because of the shoulder effect. There is going to be an interaction between the protominated and the non-protominated fractions of insulin. And there is going to be a prolonged action of the non-protominated form. And this will lead to an increased incidence of hypoglycemia. And of course, I had mentioned about the flexibility of the regimen as well. And acceptability, yes, it is going to be a complex regimen, yes. But let's have a look at this study here from JCM, which in fact showed that the quality of life favored the basal bolus group more than the premixed group, and even the perceived health, the symptom distress, the general health perceptions, and psychosocial factors, everything was favoring the basal bolus regimen. So it's just not about the number of injections or whether the patient is on injection or not. It's about how it translates to better glycemic control. Because in spite of the fact that patient takes two times injection, thrice injection, 4 times injection, if the patient is not able to achieve glycemic control, it is going to reflect on the perceived health and the symptom distress as well. And now the most important point, the cost effectiveness. And this is a study which had looked specifically at the cost effectiveness, and it showed that the patients who were on basal bolus regimen, in fact, that was associated with significantly less work missed for health reasons. And the cost analysis for the study indicated greater cost effectiveness with the basal bolus regimen. And it's just not about how much the patient is going to spend on that day paying for the insulin. It's also about the hidden cost. And we have been crying ourselves hoarse over the past few years about the legacy effect, about what we have learned from the UKPDS, what we have learned from the DCCT, and how legacy effect matters. And we have been trying to tell everybody about how to strike hard and strike early in patients with type 2 diabetes to prevent future complications, to prevent the costs associated with the treatment of these complications. And this is particularly important in an Indian with type 2 diabetes because we know we developed diabetes a decade earlier than our Western counterparts. We developed the complications much earlier than our counterparts because of our distinct phenotype. And this is the morbid statistical data that I could pick up. And this is the prevalence of diabetic retinopathy is a whooping 21.7% in our population. And the CINDI-1 and CINDI-2 studies, which looked at the prevalence of complications in newly diagnosed diabetes. And this was around 13% of neuropathy. And we know, and let me not even go into the number of amputations that we have because of neuropathy, because of vasculopathy, because of barefoot walking in India, and because of uncontrolled diabetes. And the cost of diabetic foot care in India is one of the highest in the world. It's around 5.7 years of average annual income. So all these are actually the hidden costs. And this is what we need to look at. And especially living in a country where we cannot afford to be going around treating the complications of diabetes, the best bet would be to control the sugars early and aggressively, which is much more feasible with the basal bolus regimen. And I would end by saying that the premixed insulin does not triumph over basal bolus insulin therapy. in the management of Indian patients with type 2 diabetes. Thank you for patient listening. Over to you, Shomik sir.